You've probably heard it a million times, right? That depression is just a chemical imbalance in the brain. But what if I told you that simple story, the one that built a massive industry, isn't really the full picture? Not even close. Let's dig into the real, and honestly, way more fascinating story of how these drugs actually work.
So get this, our entire modern approach to treating depression with medication, it didn't start with some genius in a lab having a breakthrough moment. Nope, it started with pure, dumb luck. Seriously, the discovery that changed psychiatry forever was a total accident.
Okay, so to really get this, we've got to rewind the clock. Picture it, the 1950s. At the time, if you were depressed, the mainstream view was that this was a problem of the mind, something you'd work through with a therapist. The idea that you could take a pill for sadness, that was basically science fiction. So this whole thing happened in two parts. First, back in 1952, there's this drug for tuberculosis called ipronicid. And doctors noticed a really weird side effect. The patients were, well, they were suddenly really cheerful. Fast forward 4 years, and a totally different drug, this one for allergies, imipramine, does the exact same thing. Scientists were scratching their heads, right? Until they found the link. Turns out, both drugs jacked up the levels of a specific group of brain chemicals, which they called monoamines. And just like that, this accidental find sparked an idea. A really simple, really powerful idea that would pretty much define how we saw depression for the next 50 years. And that was it. The chemical imbalance theory was born. The logic seemed perfect, right? If these drugs make you feel better by boosting monoamines, then depression must be caused by not having enough of them. It was such a clean, simple explanation. And honestly, everyone, doctors, patients, the public, they all bought into it. So this theory really focused on three main players. You've got serotonin, that's your mood and anxiety regulator. Then there's norepinephrine, which is all about energy and focus. And finally, dopamine, the pleasure and motivation chemical. The story was simple. If you're depressed, you're just running low on one of these.
But, science is never that easy, right? As researchers kept digging, a huge crack started to appear in this neat little theory. A problem so big, you just couldn't ignore it.
Okay, so here's the giant puzzle. These drugs, they raise those chemical levels in your brain within hours of taking the first pill. But patients don't actually start feeling better for weeks, sometimes 4, even 6 weeks. If it were as simple as just topping off the chemical tank, you'd feel better right away. So what's really going on in that time? Well, it turns out depression is a way bigger deal than just low chemicals. It's more like a system-wide problem. Yeah, the monoamines are involved, but they're just the first domino to fall. What we think now is that things like chronic stress can send your brain's main stress response system, the HPA axis, into overdrive. This in turn actually makes it harder for your brain to grow and make new connections, a process we call neuroplasticity. And on top of that, it can even cause this low-level, long-term inflammation in the brain that messes with all the signals. It's a much, much bigger picture. Okay, so keeping that more complicated picture in mind, let's dive into the actual drugs we use today. And we have to start with the most famous ones of all. I'm talking about SSRIs, of course, selective serotonin reuptake inhibitors. Here's the easiest way to think about how they work. Imagine the gap between two of your brain cells as a sink. Serotonin is the water flowing from the faucet into that sink. Now, there's a drain in that sink, a little pump called SIRT that's constantly sucking the serotonin out. What an SSRI does is it comes along and partially plugs that drain. So more serotonin stays in the sink for longer, making the signal between the cells stronger. Simple as that. You've definitely heard of these. We're talking about drugs like fluoxetine. You probably know it as Prozac. And the reason they became so popular is because they're way more targeted than the older drugs, which usually means fewer side effects. That's why they're often the first thing a doctor will try, not just for depression, but for anxiety, OCD, PTSD, a whole range of things. But of course, they're not perfect. They do have risks. A lot of people feel nauseous or even more anxious when they first start. And a big one, a really common one, is sexual dysfunction, which can be a real problem for people. And then there's the most serious risk, something called serotonin syndrome. It's rare, but it's a dangerous overload of serotonin that can be life-threatening. All right, next up in the toolbox, we have a class of drugs that takes a slightly different angle. These are the SNRIs. And instead of just plugging the serotonin drain, they plug the drains for both serotonin and norepinephrine. It's a 2-for-1 deal. And this can be super helpful for people whose depression comes with that deep physical fatigue and lack of energy, because that norepinephrine boost can really help with alertness and drive. So we're talking about drugs like venlafaxine and duloxetine. And here's something really interesting. They also work really well for chronic pain, like fibromyalgia. It just goes to show you how connected our brain's pathways for mood and pain really are. The one big thing to watch out for, though, since they're boosting norepinephrine, which is kind of like a cousin to adrenaline, you have to keep an eye on blood pressure. It can definitely tick up. Okay, now let's step into the time machine and go back to one of the OG classes of antidepressants, the tricyclics, or TCAs. Now, TCAs work, they're effective, but in pharmacology, we'd call them dirty drugs. And here's why. Think of it like a key. An SSRI is like a precision key that only opens one lock. A TCA is like a sledgehammer. Yeah, it'll open the door you want. It blocks serotonin and norepinephrine reuptake just like an SNRI, but it also smashes into a bunch of other locks or receptors on its way. And that's what causes all those classic, really annoying side effects. Dry mouth, feeling drowsy, constipation. But look, if you remember one thing about TCAs, make it this. They are incredibly dangerous if someone overdoses on them. They can completely mess up the electrical rhythm of the heart, and it can be fatal. On an EKG, it shows up as this classic warning sign called a wide QRS complex. And that risk, that lethality and overdose, is the main reason we just don't use them as a first choice anymore. All right, last but not least, we have the oldest and, you could argue, the most powerful class of them all. These are the MAOIs, monoamine oxidase inhibitors, and they have a totally different strategy. If SSRIs plug the drain, MAIs go after the whole garbage disposal system. There's an enzyme in the brain called monoamine oxidase, and its whole job is to chew up and get rid of these neurotransmitters. And MAOI shuts that enzyme down. And the result? A huge flood of all three big ones: serotonin, norepinephrine, and dopamine. But all that power comes with some serious strings attached. And I mean serious. If you're on an MAOI, you have a strict diet. You can't eat foods that are high in something called tyrannomine. We're talking aged cheese, red wine, salami, stuff like that. If you do, it can trigger what's called a hypertensive crisis, which is a sudden, crazy dangerous spike in your blood pressure. And you absolutely cannot mix them with other antidepressants. You need a long washout period to get one drug completely out of your system before you can even think about starting another. Okay, so that's the grand tour of the antidepressant toolbox. So how on earth does a doctor pick the right one? Well, it's all about weighing the risks and the benefits, which we can really see when we line them all up. So here's the cheat sheet. SSRIs, they're usually your first stop, just targeting serotonin. If fatigue or pain are big problems, you might try an SNRI to get that norepinephrine boost, but you gotta watch the blood pressure. For tougher cases, TCAs are an option. They're strong, but you have that scary overdose risk. And then you have the big guns, the MAOIs. They're the most powerful, but with those dangerous food and drug interactions, they're usually the last resort. All right, before we wrap up, let's just hammer home 3 key points, the kind of stuff you absolutely need to remember. First, TCA overdose. If you see anything about a wide QRS on an EKG after an overdose, you should immediately think tricyclic antidepressant. It's a classic and deadly giveaway. Second, for MAOIs, you have to know the 2 different dangers. The aged cheese and wine problem, that causes a hypertensive crisis, a blood pressure emergency. Mixing an MAOI with an SSRI, that's what can cause serotonin syndrome. 2 different interactions, 2 different emergencies. And number 3, when it comes to the SSRIs, the most common drugs out there, what's the most common side effect people complain about? It's not the initial nausea, it's sexual dysfunction. It's a really frequent and often lasting side effect. So, after this whole journey through decades of science, where are we? Well, we've got treatments that can and do help millions of people, but we're also left with some really profound unanswered questions. And this really gets to the single most important idea to take away from all this. I love this analogy. A steroid cream will clear up a poison ivy rash, right? But nobody thinks the rash was caused by a steroid deficiency. And it's the same logic here. Just because a drug that boosts serotonin helps with depression, that doesn't actually prove that a lack of serotonin was the root cause of the problem in the first place. And that leaves us staring at the biggest question of all. That old chemical imbalance theory, it was a good starting point, but it's just not the whole story. What we're realizing now is that our best medications are probably working on the effects of depression. They're helping with brain plasticity, calming inflammation, fixing stress responses. But are they fixing the true underlying cause? Maybe not. They're managing the symptoms, incredibly well for some, But the journey to really, truly understand what causes depression, well, that journey is far from over.